Let me get back to our patient and how we can manage her based on the guidelines. So let's look at the American Diabetes Association recommendation, which is to use pharmacological therapy at the time of diagnosis, usually using metformin unless it's contraindicated or are not tolerated. The ADA does recommend considering dual therapy for people with very high A1C at presentation, or people who are symptomatic and have very high blood glucose, say more than 300 or A1C greater than 10, maybe using insulin for a short term. For most people, choose any therapy as the second-line therapy, and when the 2 drugs fail, you can go on to the third-line therapy, which could be a third oral agent or adding in an injectable. Some of the injectables could be added on as second line, including insulin and GLP-1 receptor agonist, although patients often prefer oral therapy. Now, there are some new developments in these guidelines. The American Diabetes Association has emphasized this, as has ACE, to focus on other comorbidities a patient might have, such as heart disease. Mm-hmm. And the recommendation is to consider drugs that have had positive cardiovascular outcome trials, such as some of the GLP-1 receptor agonists and the SGLT2 inhibitors as probably the drugs to add on to metformin for those particular patients. And then we have other guidelines from other organizations. Actually, they're not that much different. And since I mentioned the ACE guideline, let me just talk very briefly about it, since I'm involved with developing that as well. The goal is a little lower in the general goal, less than 6.5, but both organizations emphasize individualization of the goal. The other difference, as I pointed out earlier, is that the ACE recommends combination therapy for lower levels of A1C, recognizing that all drugs are not strong enough to get people to goal. And the ADA often has recommended cost as being part of the making the choice, which I think is very realistic in real life, whereas ACE has focused on efficacy and suitability of the therapy.
You know, Vivian, I agree with you. These guidelines are much more similar than they are dissimilar, but I think there's a reason, and we can explore this a little later, why after metformin, GLP-1 receptor agonists and SGLT2 inhibitors are at the very top of the list. And it's not only for the A1C lowering, but it's also for those non-glycemic benefits. And as you and I are going to discuss, now we have this whole world of potential cardiovascular benefits for certain members of this class. And so I think it's going to be one of these things that continues to support that hierarchical recommendation from ACE.